As the global cancer burden rises alongside the obesity epidemic, a critical blind spot in medicine becomes increasingly clear. Obesity, despite its strong and growing links to cancer, is still not fully recognized or treated as a primary cancer risk factor in clinical practice. Body mass index, BMI, is routinely measured in general medical care, but its relevance to cancer prevention and early detection remains deeply underutilized. This gap represents a missed opportunity, one with profound implications for patient outcomes, healthcare systems, and public health at large. There is now overwhelming scientific evidence that excess body fat drives up the risk for at least 13 types of cancer, including breast, postmenopausal, colorectal, endometrial, kidney, pancreatic, and esophageal adenocarcinoma. The World Health Organization and American Cancer Society both acknowledge obesity as a modifiable cancer risk factor, on par with smoking, alcohol, and inactivity. Yet in many oncology settings, BMI is not formally incorporated into cancer risk assessments, screening frequency decisions, or patient education. This disconnect raises a fundamental question. If we have the data, why aren't we acting on it? Obesity is more than a passive backdrop to cancer. It actively accelerates disease through multiple biological mechanisms. It promotes chronic inflammation, hormonal imbalances, insulin resistance, and immune dysfunction, all of which work together to create a tumor-friendly environment. These effects don't just increase cancer risk, they also influence tumor behavior, making some cancers more aggressive, less responsive to treatment, and more likely to recur. Despite this, cancer prevention efforts largely remain anchored in age-based screening models and broad lifestyle advice. BMI, waist circumference, and metabolic health indicators are often absent from formal cancer prevention guidelines. Oncology, as a discipline, tends to treat cancer as something that strikes randomly or genetically, rather than as a consequence of long-term modifiable risk exposures like obesity. This outdated framing allows obesity's role in cancer to remain hidden in plain sight. Integrating obesity screening into cancer prevention programs could be transformative, but it will require a fundamental shift in how we define cancer risk and who we prioritize for early intervention. BMI and other markers of adiposity should be factored into decisions about when to begin cancer screenings and how frequently to perform them. For example, earlier and more frequent colonoscopies for obese individuals could catch colorectal cancers that may otherwise progress rapidly. More vigilant endometrial and breast cancer monitoring in postmenopausal women with obesity could help close the diagnostic gap that currently leads to late-stage discoveries. Beyond screening, recognizing obesity as a cancer risk factor should trigger deeper clinical conversations about weight management as a legitimate form of cancer prevention, not just a cosmetic or metabolic issue. Patients with high BMI should be counseled about their increased risk, much like smokers are advised to quit or sun-exposed individuals are urged to use protection. The goal isn't shame, it's awareness and empowerment. Most patients are never told that their weight could increase their chance of developing deadly cancers, even though the data is crystal clear. Clinicians often cite discomfort, time constraints, or fear of offending patients as reasons for avoiding discussions about obesity in oncology. But avoiding the issue doesn't eliminate the risk, it just ensures it goes unaddressed. Worse still, it reinforces the false notion that cancer is mostly genetic or random, rather than something deeply tied to lifestyle, systemic inflammation, and metabolic health. Another obstacle is how fragmented care has become. Weight is managed in primary care or bariatric settings, while cancer risk is assessed in separate specialty clinics. There is little crosstalk between disciplines, and patients fall through the cracks. A patient with obesity may see an endocrinologist for diabetes, a cardiologist for blood pressure, and a gynecologist for screening, but none of those visits may fully convey how all these conditions together elevate her cancer risk. By the time she sees an oncologist, the disease may already be present. There is also a social dimension to this crisis. Obesity is more prevalent in lower-income, minority, and rural populations, groups already underserved by cancer prevention and screening efforts. If we continue to ignore obesity in cancer risk assessments, we further entrench health disparities and guarantee worse outcomes for the most vulnerable. In this way, integrating obesity into cancer prevention isn't just medically sound, it's a matter of health equity. Even the tools we use to assess cancer risk must evolve. BMI is a crude measure that doesn't capture fat distribution or metabolic risk very well. Waist-to-hip ratio, Visceral fat imaging and inflammatory markers may offer more precise ways to stratify cancer risk in obese patients. As precision medicine advances, we must move beyond population averages and develop cancer prevention models that reflect the unique risks posed by excess adiposity. The time to act is now. With global obesity rates soaring and cancer cases expected to climb by 50% over the next 2 decades, the intersection of these two epidemics can no longer be ignored. Cancer prevention strategies that don't account for obesity are fundamentally incomplete. Public health campaigns, clinical protocols, and oncology training programs must all begin to treat obesity not as a peripheral issue, but as a central driver of malignancy. From BMI to biopsy, the path is clear, but only if we choose to follow it. The tools are available. The science is solid. What remains is the will to reshape cancer prevention in a way that reflects the modern realities of risk. If we fail to do so, we will continue to treat cancer too late, miss the chance to intervene earlier, and allow an entirely preventable cause of suffering to persist in silence.